once diagnosed, there are various treatment options that are available under the program, and these services are provided free of cost. And the program is now providing fixed dose combinations and of the first line drugs and in daily dosage form according to the weight of the patient. So these are available. Then there is for drug resistance TB, we have with the introduction of CBNAT, these facilities are available at the district level and would further be scaled up to below sub-district levels also. And so the clinician is now in a position to be able to provide DST guided treatment, which means that he can do drug sensitivity and identify the right combination of drugs that can be provided to the drug resistant cases that we have under the program. The program also is coming up with shorter regimens for drug resistant TB to reduce the duration of treatment from the conventional regimen of almost 24 months to come down to as low as 9 to 11 months in this thing. The program has also introduced newer drugs like bedaquiline and delaminide that is coming up, and these are newer drugs that have been recommended by the WHO and have already been adopted by this program. These are the services that are available for treatment, and for the program not only provides treatment but also provides supportive support in terms of providing adherence support using information technology. There are several tools. We will talk a little bit about it in the subsequent slides. Also in cases of comorbidities, especially with HIV TB, where the program has started providing single window services for the HIV patients. So the ART medical officer is trained and equipped, and drugs have been made available to him to diagnose and initiate anti-tubercular treatment at the ART center itself. So the patient does not have to move around to different centers for initiation of treatment. Also the program is trying to provide support for reducing the out of pocket expenditure by incentivizing certain aspects for giving incentives to the treatment supporters and to the patient also to help him take care of his travel or to take care of his nutritional requirements that he may have during this thing. And during the course of treatment, the financial benefits that are provided under the program are now being provided through the DBT mechanism, direct benefit transfer, where the money is transferred directly into the patient's account using Aadhaar based authentication. So that the drugs and the treatment is provided to him at a place very closest to his house or to his place of residence, and the benefits and the social protection that is required to him is also directly provided in a transparent manner. For treatment of tuberculosis under the program, the cases are classified into two based on a new case of tuberculosis or a previously treated case of tuberculosis. A new case of tuberculosis is one which in which the patient has not taken anti-tubercular treatment for at least a month, and if he has taken anti-tubercular treatment for more than a month in his previous history, he would be considered as a previously treated case and given appropriate treatment. So for a new case, the intensive phase covers 4 drugs, which is now provided in a fixed dose combination, and the drugs that are there in that combination are isoniazid, rifampicin, pyrazinamide and ethambutol, and the intensive phase is given for 2 months. At the end of intensive phase, the patient is then initiated on continuation phase, which goes on for 4 months, and the program is now providing INH, rifampicin and ethambutol as a combination in a fixed dose combination for 4 months. So a new case of tuberculosis gets 2 months of intensive phase and 4 months of continuation phase. So a treatment duration of 6 months. For a previously treated cases, apart from the HRZE that we say for our the first line drugs, additionally streptomycin is added into his treatment regime, and this is given for 2 months, streptomycin, and after that he is given HRZE, the fixed dose combination, for another month. That covers the intensive phase for previously treated cases. And for the continuation phase, the drugs are the same that we give in a new case, similar to a new case, INH rifampicin and ethambutol in a combination of a single pill, and it is given for 5-month duration. So this is how the treatment regimes are given under the program for tuberculosis in the public health facilities across the country. The advantages of going into fixed dose combination, based on the experiences that the program has achieved over the years, the program has moved to fixed dose combination and daily regime, and this is also now the program is able to provide these drugs based on the body weight. So these FDC combinations are available in and are helping us to provide treatment according to the weight of the patient, so that the right level of drugs is available in his body and the outcomes are better. Also, there is no need for any extension of intensive phase, and in both the continuation phase in both new and previously treated cases, of course the based on scenarios which the clinician can decide for different certain forms of tuberculosis, like neural tuberculosis or the tuberculosis of the bone or spine. It's up to the clinician, and he can extend the continuation phase if he feels it is appropriate. In cases where extension is given beyond 12 weeks, they should only be given on the recommendation of subject experts based on the type of tuberculosis, and they, of course, if there is any adverse reaction that the patient experiences, then there are loose drugs that are also available under the program, so that the right combination of drugs can be given to him. In the adult, the fixed dose combinations that is available under the program, like I said, for the based on the body weight of the patient, you will see that there are these drugs are available in as a single pill, and it has combination of HRZE in the intensive phase in a dosage of INH at 75 milligrams, 150 milligrams for rifampicin, 400 of pyrazinamide, and 275 with ethambutol. And this combination, the single pill, for a weight band of 25 to 39, the patient has to take 2 pills at a time. And likewise, as his body weight increases in different slabs, you'll see that the patient has to take 3 tablets, 4 tablets, or 5 tablets that is available. And similarly, in the continuation phase, the patient has to take 2 tablets of those of the FDC, but the FDC now is not HRZE, but it is HRE. So it's called 3 FDC in the continuation phase and 4 FDC in the intensive phase. So he takes 2 tablets of that, and 2, 3, 4 or 5 based on his weight band. And streptomycin is added for retreatment cases that continue separately, that is not available in the fixed dose combination form. For the pediatric cases also, the drugs are now available in fixed dose combination, and it is also child friendly. The drugs are available in a flavored taste, so that the the children can take appropriate treatment rightly. So in the pediatric age group, again these fixed dose combinations, ethambutol is something, being a hygroscopic formulation, is not currently available in the fixed dose combination. So the FDC has INH rifampicin and pyrazinamide, and ethambutol is given separately. However, even the ethambutol tablet is dispersible, and it is available. So based on the weight band, the child has to take 1, 2 or 3 tablets which are dispersible and flavored, and he takes it. As the weight band increases, if the child is about 25 kilos, 1 tablet of the adult form is added into it for the intensive phase, and similarly for the continuation phase. So these are the different drugs that we have for adult as well as pediatric form. and in the fixed dose combinations, which is very patient friendly, and it helps in reduces the pill burden, and it helps in treatment adherence and compliance. These drugs that are given under the program is provided through direct observed as direct observed treatment. So, the patient is supervised physically by someone. So, the services are now to help the patient take those medicines. I mean, it would be very difficult to expect him to come to a health facility every day. So, of course, if he is willing, these services are available in the health facility, or there is a community treatment supporter that can be identified based on the convenience of the patient, and including a family member is now could be a treatment supporter himself. And so, the drugs are given to the treatment supporter. It could be a family member, could be a community fellow out there in the community, wherever the patient wants to get it, or if the patient wants to come to the physical facility, they can also come to the public health facility, nearest public health facility. Apart from giving the medicines, there are other IT interventions which I told about to help in adherence of those patients. There are tools like what is called as 99 dots, wherein the patient just has to, after he opens the blister, there is a random phone number behind it, a toll free number. The patient just has to give a missed call, and the system identifies that the patient has opened and taken the drug. Similarly, there is a tool called as a pill box, which is again every time the patient opens the box to take the drugs, an alert goes into the system, and the system identifies that the patient has taken the drug. And there are other options available of SMS. The program gives reminder SMSs to the patient who is registered with the program, so to remind him for taking the drugs, or to remind him for coming for follow-up investigations. So, these are the different adherence support that is available under the program. So, once a patient is diagnosed and a medical officer decides to initiate him on treatment, a treatment card and a treatment patient ID card is generated. It is then it decides on the, I mean, the medical officer decides on the category of treatment that is to be given to him, either a new or a previously treated. So, these drugs are available, and once these drugs are available, the treatment supporter for the patient is identified, and this is identified mutually by the patient and the provider. So, whatever is convenient for the patient, any person he wants to identify as a treatment supporter, these drugs are transferred to that treatment supporter, and he is advised and counseled and explained on all the requirements of monitoring treatment, including recording and reporting of the dispensing of drugs. Once the treatment supporter is identified and drugs are made available to him, the treatment supporter and the patient is also visited by a healthcare provider like the ANM or the senior treatment supervisor, which is available under the program. They go and weekly ensure that whether the treatment supporter is providing drugs and recording and reporting it in the right manner. Once these treatment supporter continues to provide all those things, all the drugs to the patient, also the follow-up investigations as per the requirements is ensured, and the information is entered into MIS system called as NICSHE in the program. The various treatment support structures, like I said already, includes counseling, treatment supporter is identified, IT based adherence tools are available with it, adverse drug reactions are being monitored closely, there is nutritional support that is being provided, and various other support mechanisms are now being made available to the patient, and these support structures are being provided to ensure that the patient is taking the treatment and completing the entire course of treatment, and becomes clinically free of tuberculosis. The follow-up, like I said, that is required for a tuberculosis patient. There is clinical follow-up which is supported by laboratories investigations also. So monthly, even if the treatment supporter is right next door, the patient is expected to come once a month to be examined by the medical officer to the nearest public health facility where he can come and get his checkups. Also there, during those monthly visits and screenings, the symptoms are the various symptomatic examination, looking for adverse drug reactions, the weight, monitoring the weight and looking for other comorbidities, and X-ray if required. All these services are available even for follow-up. And the laboratory support that is required for follow-up in terms of smear microscopy or drug susceptibility testing that is required, or investigations, any other investigations for maybe adverse drug reactions that come in, or for comorbidities like HIV or diabetes, or any other comorbidity if the clinician is suspecting, those investigations are also followed up. The follow-up protocol has now been revised. Initially, in the earlier times, once the patient has completed his intensive phase, continuation phase and end of treatment, the patient is discharged from the program. The follow-up mechanism was not there. Now the follow-up mechanism is available, and after treatment completion also the patient is followed up right up to 24 months, at frequencies of 6 months, 12 months, 18 months and 24 months after his completion of treatment. And once he is completed his treatment, at all these subsequent visits, either a smear or culture is done to ensure that the patient doesn't relapse or doesn't have a reinfection of tuberculosis. So based on the follow-up investigation earlier, after the intensive phase, there is if the sputum smear continues to be positive, he is now offered culture DST. The molecular technology CBNAT is there to identify drug resistance. So the concept of extension of IP is no more there. So once at the end of intensive phase, if the patient is continues to be smear positive, he is offered DST and first line DST, and based on that DST he is provided the appropriate regimen if change in regimen is required. Thank you for the patient listening to this session.